Thank you very much. Thank you very much, Liz. Thank you everyone for joining us today on the Learning Health System in Action session. Today we are going to be discussing the NYU Langone model. But what are learning health systems? I think first we need to consider some of the definitions that exist. The Health Foundation has described the learning health system as an engines of innovation and improvement. And in 2006, when the then Institute of Medicine had their workshop on evidence-based medicine, they considered the learning health system approach a product, their first product of that session. Some of the discussions that ensued during that session was the over-reliance on the randomized control trial. So aspects of how expensive trials are or how slow they were, and the issues fraught around generalizability of what we get from randomized control trials in order to improve ourselves. So today we are very privileged to actually have the opportunity to understand an actual learning health system in action in the NYU Langone model. I'd like to introduce Dr. Leora Horwitz, who is the director of the Center for Healthcare Innovation and Delivery Science at NYU Langone Health. Leora is also the director of the Division of Healthcare Delivery Science in the Department of Population Health at NYU School of Medicine. We also have in this presentation Holly Krelle. Holly is the program manager of the Rapid RCT Lab and is a senior advisor for the Health Foundation. Holly has also been a Harkness Commonwealth Fellow and was a principal analyst in our own NHS. So let's listen to the presentation now.
Thank you. It's a pleasure to be here. Today, we're going to talk about the Rapid Randomized Trial Lab at NYU Langone. My name is Leora Horwitz. I'll be speaking at the beginning, and Holly Krelle, our program manager, will finish up the presentation. We're going to talk about how NYU Langone is a learning health system. A learning health system is a system in which science, informatics, incentives, and culture are aligned for continuous improvement and innovation, with best practices seamlessly embedded in the delivery process, patients and families active participants in all elements, and new knowledge captured as an integral byproduct of the delivery experience. This is what we seek to achieve here at NYU. And today I'm going to talk just about this last piece. How do we capture knowledge out of the streams of data that we are generating as just sort of integral parts of our delivery experience? So how do we do that? We run studies. We run studies that are short because we quickly want to know what is working and what is not working. We run studies that are randomized because that is the most effective, most efficient, and most unbiased way of determining what works and what doesn't work. We run studies that are repeated because almost never do they work the first time. We iterate and we adjust and we trial and we test again, just like our quality improvement colleagues have been doing for many years. And most importantly, we organize our studies so that they are invisible to the front line. They are no extra work. We randomize things in the background. We look at data and outcomes that are already collected as part of routine clinical care so that we can embed these trials into routine practice. NYU Langone is a large health system, an academic health system in the US, in New York State. We're based in New York City. We have over 44,000 staff members, over 2,000 inpatient beds spread across 3 major hospital centers in Manhattan, Brooklyn, and out on Long Island. Collectively, we take care of about 8 million people, but those people do not get their care only at NYU. They get care partially at NYU, partially at other places around New York. We provide primary care, secondary care, and tertiary care. And we have over 320 outpatient locations, offices, as well as our inpatient beds. Let me give you just a handful of examples to give you a flavor of the sorts of projects that we can run here. We are agnostic to population, to topic, to location, to specialty, to problem. We are interested in improving the delivery of evidence-based standard of care across our healthcare system. One challenge that we have is we are responsible for a population of patients. We are held accountable to their quality metrics, to the degree to which they engage, for example, in preventive care. And so we often are finding ourselves wanting to reach out to our populations and remind them to come in for care, but we can't call all 8 million people. And so we need to triage, we need to prioritize who we call. It would be most efficient for us to target those who are most likely to respond to our phone call, so we're not wasting our time. But we don't really know who they are. It could be that there are people who will go and get their preventive care on their own without any phone call. It would be a waste of our time to call them. It could also be that there are people who are never going to have a colonoscopy, no matter how many times we call them. They would also be a waste to call. So how do we figure out who is most likely to respond to our call? Well, we don't know up front, so we decided to test that. We built a model to predict the likelihood of someone doing their preventive care on their own without a phone call. And then we ran a trial to see which group benefited most, either from a message in the patient portal or from a telephone call. We divided our population into quartiles, into groups of 25%, according to their risk of doing the test or the likelihood of them doing this test on their own versus not doing it. Everyone who already had a patient portal account, we randomized within those quartiles to receiving a portal message or not. That was about 20,000 patients. Everyone else who didn't have a portal account, we randomized again within those risk quartiles to getting a telephone call or not. That was about 14,000 patients. You can see here on the left that the patients who have a patient portal account were very responsive to the message that we sent across the board, whether they were unlikely to get the test on their own or likely to get the test on their own or unlikely. Either way, they were all pretty much equally responsive. Whereas the people who didn't get a message, they largely didn't make appointments because they had perhaps forgotten they were due. The people who did not have a patient portal account are less engaged patients, definitionally, but they too responded to our phone call at a lower rate than the chart, but they responded. But here you can see that they responded differentially by risk. Those who were most likely to get the test on their own without a phone call responded less to our phone call than those who were at greatest risk of not doing the test on their own. That is, the people who were most recalcitrant actually responded best to a prompt from our callers. So the telephone intervention was most effective for the highest risk patients, and now that's how we make our calls. We prioritize them first. Pediatric vaccination rates is another challenge that we have had in our health system, especially after the COVID pandemic. Pediatric vaccination rates, especially at our federally qualified health center, which is a special set of clinics we have for underserved populations, people without insurance or otherwise unconnected. Those populations tend to have low portal use. They often don't speak English. They don't have access to electronic to the web. So we decided to try text messaging these parents to alert them that their child was due for a vaccine. First, we sat down with a bunch of our patients and we asked them, what would motivate you? Why aren't you coming in for the vaccine? What are the challenges? And many of them said, we're afraid of COVID. This was back in 2021. We don't want to be anywhere near their healthcare system. And other people said, I don't even know what these vaccines are for. Is that really important for my child to get them? So we created two different focused text messages to see which kind of prompt would be most effective. On the left, you'll see message A, focusing really on safety and cleanliness. Your child is due for a vaccine. Our staff are screened and they're COVID tested. It's safe to come in. On the right, we had a message that was really focused on the value of vaccines. Your child is due for a vaccine. Vaccines prevent your child from getting sick. Visits are fast. Come in. And then we randomized a third arm without a reminder message at all. Unfortunately, we found no effect whatsoever of these messages on appointment rates or vaccination rates. So we went back to the drawing board and thought, well, maybe these are just too complicated. Maybe we just need to back up and send a message that says, this is a reminder to schedule your child's routine vaccination appointment. Let's make it just feel normal. Let's not seem like we're trying too hard. So we tried that message versus no message at all. That too had no effect. So we went back and we called up the parents who had received the message. And we asked them, what happened? How come you didn't make the appointment? And many of them said, oh, I got that message. I meant to make the appointment. I just forgot. Or I got the message and I was in the middle of work and I couldn't stop to make the appointment. So we decided to run a third round of trials, this time with 2 text messages. First, we sent a primer message in the evening on a weekday. It said, your child is due for a vaccine. Schedule online now or call this number tomorrow. And this time we were able to include a link directly to the clinic where they could schedule. So some people who had access to the web who were receiving this in the evening could directly make the appointment. But then 2 days later at noon, when we were hopeful that many people would be on a lunch break if they were working, we sent another message. We have reserved your child's next vaccine. Call this number or schedule online to make the appointment. So we hoped that both the combination of timing things correctly so that we would reach people in the moment where they were available, adding an ability to get to it online, sending the reminder, and using this word reserved, which has been shown in literature to be a helpful behavioral kind of prompt, would be helpful. And sure enough, we did see a benefit this time for the first time. So in the purple, you will see the control group. These are people who are not getting a message, but they're all due for vaccines. So there's some base rate of people scheduling appointments. After the first text on Tuesday night, but before the second one, a substantive number of people make appointments right away, many more than just the random number in the control group. Within a day after that second reminder text, though, that rate triples, and it continues to go up even 3 days after that. So we find for the first time that this approach worked, and now that is our standard across the rest of our pediatric clinics. We are implementing this as just a standard approach. Finally, oftentimes when we reach people with these reminder phone calls, they don't agree to make appointments. And so we ran another set of studies trying to figure out what could we say to people that would be most effective in helping them to agree to make an appointment. Ultimately, we landed on one that had a more precise introduction, really putting a call to action at the start and directly helping to make the appointment. And I'll show you what that means. So the original script that our call center was using, developed just sort of off the cuff by what people were thinking at the time, said, my name is Leora. I'm calling on behalf of Dr. Horwitz at NYU Langone to ensure that your healthcare needs are being met and that your health record is up to date. Is this a good time to talk? I only need a few minutes of your time. And then later, if they agree to continue the conversation, the caller would say something like, would you like me to help you schedule an appointment with Dr. Horwitz for an annual well visit? So by the time we get to our third iteration, we had realized that all of that really needed to be updated. We changed it like this. My name is Leora. I'm calling on behalf of Dr. Horwitz, NYU, because we have noticed you haven't been here this year, and we would like you to come back for your yearly checkup. I can schedule it right away. It will only take a few minutes. Is this a good time to talk? So now in the intro, immediately we have set up why we're calling. We have made it clear that we've looked at their records. We think that they are due for something, and the call to action is clear. It also allowed people right up front to say, no, I'm not interested, which shortened our phone calls and freed up time for us to call other people. If they do say, yes, I'm interested, then later the caller says, I can go ahead and help you schedule that appointment. I can do that right now, as opposed to, would you like me to do it? Maybe I could help. So being more forceful and more assertive. And this is what we found. Again, we ran multiple iterations. I just showed you the third iteration. Each of our iterations improved very slightly, but that third iteration was really substantially better. Each round had about 250 adults in it. This is about a 54% increase versus our original, and with a p-value of 0.11. We did it again with our pediatric phone calls. Here, parents are better at making appointments for their kids than they are for themselves. But nonetheless, even with the children, this third iteration improved appointment rates substantially. I'm going to turn the conversation over now to Holly Krelle, our program manager, who's going to talk about how this approach could apply to the NHS.
Hi, everyone. Yep, so as Leora says, I'm going to talk now a bit more about the practicalities of how we do this at NYU and how you might apply it within the NHS context. So first of all, talking about our team, what does it look like? What do we do? So our team itself is pretty small. It has one director, Leora, a program manager, me, who has, and I think this is quite important, a mix of a kind of evaluation background and more of a delivery background, and I'll come on to why that's important in the future. We then have 2 data analysts, so people whose main job is kind of statistics, 1 data extractor whose whole job is basically getting data out of our EHR, 2 project associates to do the coordination and the management, and then a statistical advisor. And with that team, we can run anything between 10 to 15 trials at a time. And there are some kind of really key features of this team in the way we work with the hospital system. And I think what's important to highlight here is some of these need to be in a very local situation. They need to be in an individual hospital, but other ones of these could be in a kind of more hub or a more central organization. So in terms of the kind of local things, the things you have to have in your hospital system will be, number 1, senior level sponsorship and buy-in. So we report regularly to our C-suite. We have their support. If ever anything's happening or we need wheels greased, we can go directly to very senior sponsorship and get that kind of weight behind us, and that's really important. Secondly, we have frontline staff willing to design and test ideas. Nothing we do comes solely from us. These are all frontline staff who have things that they want to do, and they're willing to let us play with them and manipulate them and run randomized trials on them. You have to have frontline staff who are going to be willing to work with you in this way. And then lastly, we have the ability to manipulate our EHR. We have an MCIT and IT department that's very on board and is happy for us to be playing with that EHR, to be changing things like call scripts, to be sending out text, to be altering alerts within our EHR, and that's essential. Then there's another set of things which, again, for us are still within NYU, but in an NHS context could be in a more centralized organization. So these are easy and immediate-ish access to data. So we're using data at every stage of our project development when we're developing ideas and when we're seeing if they worked or not. And you need to have immediate access to data. You can't be waiting on permission to access it. So you need some way of getting that quickly. Secondly, some people come to us with pretty fully formed project ideas, but most of the time we're taking projects through ideation, delivery, and analysis, and we're helping the teams with each stage of that. So we're helping them with brainstorming and ideation, we're helping them with kind of project management to get things moving, and then we're doing basically all of the analysis at the other end. And again, that's a kind of set of skills that have to sit within a central team. And then lastly, the kind of hub and central model could have kind of shared tools and shared interventions that you could try and share between different hospitals and different systems. The second thing I think is really important to talk about is how we motivate people to work with us. So as we've kind of alluded to, we try very hard to make sure all of our projects sit in the background. They're not extra work for the front line, but nevertheless, we're relying on the goodwill. We're relying on the frontline staff to want to work with us, to want to trial things. And we do that in kind of a mixture of ways to motivate them. So in terms of the kind of soft encouragement, what we do is we work really, really hard on building relationships, on building trust, on building enthusiasm. Like a big portion of my job is just trying to make friends with people in this hospital and persuade them that they want to work with us. Secondly, we work really hard on finding their motivation. What is it that will make a particular frontline team want to work with us? What is annoying them? What's something they're doing that they don't want to do? What's a problem they want to fix? Like find the hook, find the motivation. Thirdly, and I think this is super important, is we stick around when things don't work out. So as the example Leora just showed, often our trials fail the first time round. We show no effect. This is something a team was really excited about. They were keen to try it, and then we come along and we prove that it was ineffective. And that could be a real problem if we just proved that and then walked away. So we make it very clear that when things don't work out, we stick around, and we stick around until we've done something useful for that team. And that, again, to go back to my first point, builds trust, builds enthusiasm. And again, to reiterate, we run trials that really don't burden the front line. If we were running a trial that was massive amount of effort for frontline teams, and then we showed it didn't work, you can see how that would be problematic. But for the most part, they're not a big lift for people. So even if they fail, it's not a huge burden on them. And then we also try and use some sort of stronger levers as well. So we tie things very clearly to measured outcomes. So in our case, targets for the C-suite or targets that come to us from our insurers or our funders, in your case from NHSE targets or board priorities. And we also try really clearly to, whenever we can, link into cost savings. So particularly in our case, we have a lot of targets where you've just got to meet a threshold in order to get a certain benefit. And so we work really hard on those things. We've just got to get this little extra bit to get over a target. That can be a really useful place to focus work. Okay, so what about what might be harder in the NHS than in our context? Well, the really obvious one is, of course, less money. NYU is a very well-funded healthcare system in a very different fiscal environment in the US. But what I would say is that, generally speaking, our team is not a particularly expensive resource, and what we do is not that expensive. So the staffing equivalent, taking out Leora, is someone around a band 8C or 8D who's running that team, a couple of band 7 analysts and some band 6 coordinators. And with that, you're running as I said, 10 to 15 trials at a time, and that's upwards to 20, 30 in a given year. And that's also with my team working on other improvement projects as well at the same time. So it's not a huge investment. This could very easily come from an existing NHS trust as an analytical team. Again, all of our projects that are going on are existing work. This isn't new stuff that's going on in the hospital. We're just manipulating existing QI work or manipulating existing new innovations that are coming to the hospital. There's not an extra cost to what we're doing. And then lastly, we obviously at NYU leverage extensively the experience we have from NYU the university as well as NYU the hospital, and that's of course true in many UK health systems. So leveraging the expertise you might have with academics, particularly when it comes to coming up with ideas or doing the kind of literature review behind certain innovations. The second thing that I think would be a real challenge is around QI or ethics approval. So here, almost all of our projects are classified as QI, and we don't have to go through ethics approval to do any of them. And that's really essential because it means that we are not slowed down by that process. We're not having to get consent, which in many cases would be simply impossible. It allows us to be sort of fleet-footed and rapid. And that's something you'll have to work out how to do within your individual trust. Here, it took Leora a lot of work working very tightly with our IRB to talk through why what we're doing is QI, not research, and make them kind of comfortable with that. And just because something's randomized, it doesn't really mean that it's research. It just means that it's really robust QI. And then lastly, and most importantly, as I said, most of our projects rely on kind of using and manipulating our EHR, doing randomization within the EHR, playing with alerts, sending texts. So you need to have experience and confidence in using your EHR in that way. So you need to be thinking about trusts that already have that capability and are used to using their EHR in that way. Finally, to conclude, what would we say to conclude? So I think the main thing we want people to take away is that it can be done. This is very much doable. It isn't a huge effort, and we have in NYU managed to embed this kind of rapid, robust trials in the day-to-day life of the hospital. So it absolutely can be done, and it can be really useful. You're not going to completely change the major problems facing the NHS. You're not going to fix the waiting times, but you can make small, meaningful improvements in a way that isn't massively burdensome to the front line. But having said that, you have to be aware that most of your trials are going to fail, certainly the initial ones. So you have to make sure that the way you build this infrastructure is that you make it routine, you make it inexpensive, and you make it low effort for the front line. Thank you very much.
Similar to the other sessions that you've attended today. Joining me for this part of the session will be Leora Horwitz, who you heard from. Unfortunately, Holly will not be able to join us today. We also get the opportunity to introduce Bob Evans. So Bob Evans comes to us as a patient representative with a wealth of experience, having been on the board of the Centre for Perioperative Care here in the UK. Bob has also worked with the Royal Academy of Medicine, going round involved in the accreditation scheme for the Royal College of Anaesthetists, even having a hands-on approach towards going to review systems working in departments where anaesthetic colleagues have been in. We're also joined by Professor Mary Dixon-Woods, whom you all know and heard from this morning with an excellent keynote presentation. Mary is the director of this institute. So just before we get into the questions, which are coming in quite thick and fast, which is great, I think we'll start off with warming our voices with a few questions. I'll go round. I'll start off with Leora. Leora, everything you said made perfect sense. We had things around waste reduction. We had about timing things correctly, effectiveness, motivating people. It just seems so correct. In terms of what you think, why is this not more widespread? Why is your approach not happening everywhere?
Oh, I wish I knew the answer to that. It's a good question. I think it's a combination of things. You know, as Holly said, you do need some degree of intentionality and infrastructure and comfort with data. So you need to be deliberate about it, and that does take a little extra time, a little extra effort, and it's often easier not to. I think a second reason is that these do seem obvious. And so many people already feel that what they're doing is obviously right. or, doesn't even need to be tested because clearly, people will respond to X or Y. And so we fall into this trap of just assuming that what we're doing is the correct thing without actually knowing if that's the case.
That's really interesting in terms of also being intentional and having that buy-in just initially. And I'd like to bring Bob into this as well. In terms of, I think obviously the patient voice might have a key part in getting that intentionality and getting people to think this is really important. On reflecting on what you've had, Bob, have some of those examples run close to you in the perspective of a patient? What are some of the challenges or some of the things a patient might think of when they hear about these ideas?
Yeah, sure, Christina. Can I just say what great sessions we've had this afternoon? My head's buzzing. But let's not get into diagnosis uncertainty. We've had that and done that today. So, these rapid randomized controlled trials, I think are an excellent idea, and I can see them being quite applicable to the NHS situation. I haven't come across too many of them, but I'm more familiar with the sort of full-blown research projects, which are by definition quite lengthy. Even the SNAP projects that we do at the Royal College of Anaesthetists are quite long-winded things, very worthy and always have great outcomes. But these rapid trials, I think, have the great advantage of being quick and can offer a quick fix, notwithstanding the fact that many of them will be iterative. Don't get it right first time on many of them, and lots of them will fail. But that doesn't matter, because the ethos of it is that the team organizing these things will still be there to run a different variation and get the successful outcome that we need. So, there's lots of advantages that we can probably draw on later in our discussion for now, but that'll do for me for the moment.
Thank you very much, Bob, and very insightful. I think I'll bring Mary into this discussion right now and ask her more a question that I'm not sure, Mary, probably you can answer this. So we understand what the model looks like in the US, but we obviously have a different structure here. And Leora has already talked about what you need to overcome. Can you reflect on some of the things that might be the barriers we need to break down in our NHS system in order to have this happen more rapidly and for people like Bob to see it more happening more frequently?
Thanks very much, Christina, and thanks to Leora and Holly for a fantastic presentation. Really enjoyed it. To me, it seems really inspiring what's happening here. And I think the emphasis on delivering evidence-based care for the benefit of patients is right at the heart of it. And while rapid randomized controlled trials sounds scary the first time you say it, essentially what you're doing, and Leora said this in her presentation, is making QI more rigorous. Essentially, it's a statistical change rather than anything else. So when we use QI methods that use, say, statistical process control, essentially we're just using a less rigorous way of testing whether the intervention has worked. The intervention to improve care has worked. The reality is most QI interventions don't work either. We just aren't quite as good at figuring out that they don't work. So I think this is a wonderful model. I don't see any reason in principle why we can't use it in the NHS, and I'm actually determined that the next project that this institute does is to introduce it as a demonstration project. And we've had some great conversations with Holly already. Very, very keen to get staff and patients engaged once we have got our own little team set up here. And I was so pleased to hear Holly's emphasis on getting the team right, building the relationships. And I'm very, very keen that we put co-design principles at the heart of it. So we formalize some of these strategies for making sure we've understood the problem first, that we co-design the interventions, and then we take them through to test. But I would just love to see this scaled in the NHS and to have it as something that people feel that they have a say in and a hand in and can help improve the NHS by everybody working together.
Thanks, Mary. And so I'm just going to jump to some of the questions so that we can bring in the audience ideas. So Guy asks, how involved are patients in the selection of the learning health system projects or the development of solutions? And I think this is probably for you, Leora.
Yeah, this is a great question. And I will say that for us, it's an area we're really trying to improve. I would say that the majority of the time they're not involved. I showed you some exceptions. For example, when we were trying to figure out a message, to parents for vaccines, we asked the parents, what's important to you? But I would say that most of the time we don't have the opportunity to do that. Sometimes that's because we're targeting our physicians or our nurses or whoever else is working in the hospital. And there we think of our physicians essentially as our patients, and we'll go and talk to them. What is important to you? What is the challenge? What message would be meaningful? But sometimes we are targeting patients, and there we still don't talk to them. And so, and that's not because we don't think it's important. It's just because we haven't worked out a good way of us finding people and doing this kind of focus group or discussion with them, right? We don't have a mechanism within our health system of just having patients kind of available for this kind of interaction with how we design care. We do have a patient advisory board, but that's not really their main focus. And I think it's a lack. So this is something we want to improve.
That's really interesting. It ties into what Mary said in terms of the vision. If we are to start to scale this up in the NHS, is to have that co-design aspect coming into the fray. I just wanted to now lead into some of the second question that's been most upvoted here, which is, are there any concerns or issues over data quality in the learning health system rapid RCT approach? We obviously always consider data, whenever people start hearing the word data, there's always that fear. But again, Leora, have you had issues around the data quality?
Oh, we always worry about data. And we got burned early on several times by not pulling the data up front. So trusting people when they say our vaccination rate is poor or whatever, or assuming we would be able to get to X, Y, Z data point. So now we always make it a point that before we start any project, we pull all the data as though we had just finished the project. We pull all the outcomes that we are interested in, all of the assignments that we're categories that we're interested in, and most of the time it's fine, and then we proceed. Sometimes we discover, in fact, that data point is not available or it's inaccurate, and in fact we've ended up doing a number of really useful other quality improvement activities around fixing data as we go along with this project.
Yeah, I think we would imagine that there's some work around actually getting the data right and working with clinicians as well. I'll just bring Bob into this as well. Any feelings about how patients would feel about the use of their data in this way?
I think there's so many safeguards as to confidentiality and anonymity. I don't think it's going to be a great problem. And I think most patients would realize that by either consenting explicitly or by any other means, that this isn't going to be a handicap in terms of moving forward with learning systems like we've heard about.
Absolutely.
I do think, though, that patients can be further reassured on this point by being involved at the co-design stage. And although many projects will come from the staff upwards because they identify problems that the learning systems can then address, brings a team on board and gets their full engagement, that you still need to have a patient view somewhere along the line, and that will help perhaps reduce the iterations that you have to go through before you find the right solution.
Thank you, Bob. Mary, I think this also ties into the concept of, when you talk about data and confidentiality, what is improvement and what is research, and that tension. Do you think we're at a point where we might overcome that? And any views on how, if we are still a long way from that, any views of how we can overcome those issues of we're using this data to improve things and it's not just research?
Yeah. This feels like a really important question, and I think we've gone some way towards resolving it, but we haven't completely got there. Leora talked about the amount of time she had to invest in negotiating with her own hospital about this, and it's actually still the case in the NHS that if you want to do what's called a service improvement project, you negotiate just with the hospital or trust that you're going to do the project in. And this is where research was 20 years ago, and it was solved by essentially setting up a large institutional infrastructure in the form of the HRA to sort it out. I think while we don't want to reproduce that huge behemoth for quality improvement, I think we need some standardized quality improvement governance process that takes care of this. And once a project has been deemed quality improvement, it's got a system around it, it's got accountabilities, it's got reporting structures, and basically everyone is protected, the patients most of all, the people doing the improvement, and the organizations. Thank you.
Thank you very much, Mary. We have a few minutes, so I'll try and get through at least one other question, if not two. So Brent asks, how could the learnings of your learning health studies be reused or scaled up to other healthcare organizations? Now, you've touched on this a little bit, but maybe you have something more to say about that, Leora.
Oh, this is our top priority for our coming years. We would love to see other health systems not only adopt the process that we've been talking about, but even see if we could replicate some of the specific trials and findings that we've had. We do call all of these quality improvement, and in the United States, one of the defining differences between quality improvement and research is the intention to generate generalizable knowledge. And so, we always talk with our own health system about the fact that that's not our goal. Our goal is to improve the care of our patients. That's our primary goal. That's what makes it quality improvement. But we would like to know, actually, as well, if it's generalizable. So I don't know the answer to that, but it is certainly of interest and importance.
Thank you, Leora. And I think we probably have room for one more question, which is Jan asks, what works well for building that goodwill among the frontline staff to test and design ideas?
Well, I think the great thing about healthcare is that it's really mission driven. It genuinely is. People come to work wanting to improve care for patients. They come to work wanting to do the right thing. And so when you go to a group and say, in what areas are you frustrated? Are you not delivering the care you think you should? Or in what areas do you think you're delivering outstanding care and no one believes you and you want to make it bigger and you need more funds and you have to prove that it works? Or in what area are you, sort of spending too much time on something that you're not sure is effective, whatever. When we talk to people about what their own priorities are, it's quite easy always to find projects that we can then intervene on. And then people are really invested because they want to improve.
Thank you very much, Leora. And those are very strong points to finish up the session with. We really need to invest in things that people find important. I'll now hand over back to Liz. Thank you very much to all our panelists.